right, so welcome to today's Project Echo Dementia. We'll start with a couple of reminders and notes, and then today we will actually go through introductions because we have a couple new folks. And then we're very fortunate to have Erica Campbell, who's going to talk to us today in our didactic about denial of diagnosis. And then we'll have a case presentation with Patricia Weber. All right. So if you're not able to, well, in any event, please enter the names of everybody who's in your room attending from your site. And when you're not speaking, please mute yourselves and then unmute and say your name. And if you can, we really appreciate seeing your face, though understand that that may not always be possible given bandwidth constraints and so forth. So we're glad you made it anyway. So either way, we're glad you're joining. We take, private health information very, very, very seriously. So during our echo, we do not disclose any information that could violate privacy. Nothing that could reveal anything regarding the person who's living with challenges or family members. And please note that all of our sessions are available, recorded, and maybe since there's new folks, we can add that link into the chat. That might be helpful. And then please do also complete a 1-minute survey. We want to improve this, and it's really through your feedback and input that we can do so. We learn so much together. So here are, okay, reminder. Next echo, so we're the 2nd and the 4th Friday of each month. Not the 2nd in August, excuse me, not the 1st in August, however. So we are not meeting on August 12th, as you see here in red. No echo session August 12th. And then we have a bunch of fantastic didactics that are scheduled into the fall, as you see here, and to the end of the year. We welcome your cases, and there's no case that's too anything really. I mean, we can all learn from a case presentation. And so we really invite you to bring a case forward and reach out to Allison via email or chat to share your cases, please. Thank you. It's really a vital part of the ECHO process. And then for CME, we have continuing education, CME and CNE, as you see here and here. And we take, disclosures very, very, very seriously. There's no financial relationship to disclose currently, and were there one, it would be very forcefully mitigated and disclosed. So we also have CNEs, as I said. Here is our very lovely map of the state of Washington with all our community sites, and we are continuing to broaden and build. So we're super grateful that we have today some new faces. So we thought we would just take an opportunity to pause and introduce ourselves. And so I'll just start, I'll stop the share. And so I'm Nancy Eisenberg, and I'm at Providence Swedish, and I'm a neurologist, and I co-lead Project Echo. And I will call on Assad.
Hello, I'm Assad Kozimi, Medical Director at PACE, Washington.
Thank you. Franja.
Hi, everyone. Apologies, I'm in transit. I'm Franja. I'm a nurse practitioner with Virginia Mason Franciscan Health, working in hospice and palliative medicine, and will be on screen soon.
Thank you. Sonia. Welcome, Sonia Hopper, and we're so glad you could join. Deborah.
This is Deborah Tillman. I'm a nurse practitioner with the Manette Clinic in Bremerton, and I see folks out in the facility setting.
And thanks, Sonia. You don't have a microphone. We're just so glad you could join. So welcome to our community. Chris.
Chris Rhodes, working remotely with limited bandwidth. Sorry, I'm not on camera. And Sonia, we can help you out with that microphone. We have budget for that. I co-lead this wonderful project with Nancy.
Great. Tristan.
Hello, everybody. Tristan Tiedemann here. I'm temporary IT support for this group, and I'm an executive assistant.
Thank you. Denise.
Hi, I'm Denise Hughes from Kitsap County. I'm the dementia specialist for Kitsap County.
Allison.
Hey,
Oops, think you may have.
I thought I unmuted. I'm
There you go.
Allison Schreier, and I'm the program manager for Project Echo Dementia.
Kimberly and Sundance. Okay, welcome. We're so glad you're here. Fantastic. We can help you with that mic issue as well. Thanks. Patricia?
Hi, I'm Patricia Weber. I'm a physician working at Fircrest, which is a residential rehabilitation center in Seattle.
Great. And Julie?
Hi, I'm Julie Delgado. I'm in Richland, Washington, work through Cadlick Senior Clinic, and I go to a nursing facility.
Thank you. Carolyn?
Carolyn Parsi, neuropsychologist with Memory Brain Wellness Center. And yes, that's who I am. Yeah.
I don't know if you say Marielle or Marielle.
It's Marielle. I'm a nurse practitioner with Franciscan Palliative Care Outreach in the Tacoma area as well as Gig Harbor.
Great. And Nicole?
Hi, everyone. I'm Nicole Kane from Aging Wisdom. We're a private care management and consulting practice here in Seattle.
Great. And Kimmy?
Hi, I'm Kimmy Demoto Riley, a neurologist at University of Washington in the Memory Brain Wellness Clinic at Harborview.
Great. Brock?
Hi, everyone. My name is Barak Gaster. I am a professor, primary care doctor at the University of Washington, and I'm the director of the Cognition and Primary Care program that's building a program to train primary care doctors to identify dementia in its earliest stages and help patients and families navigate through the disease.
Wonderful. And Trang?
Hi there. I'm Trang Lee. I'm a clinical pharmacist at Overlake Hospital Senior Healthcare Clinic.
And Mimi?
Hi there, Mimi Pattison, Virginia Mason, Franciscan Health Hospice and Palliative Care, a member of the Hub and DAC.
And Brett?
Hi, I'm Brett Hurl. I'm over in Wenatchee, Washington. Working geriatrics palliative care over there.
Thank you for making it. And then I'm going to welcome Erica, who will speak to us today about the denial of diagnosis. And Erica Campbell works at Horizon House as the social services care connector, and we're very fortunate to have you today. Thank you. And I'll stop my share.
Thank you. Glad to be here. So, let's see. Allison, I don't know if you're able to put up my presentation for me.
Yeah, certainly. So let me just check in first with Tristan to see if he has that loaded and ready to go. Otherwise, I will go fetch it.
I have it. Would you like me to share my screen?
Please, that would be perfect.
Thanks.
Thanks.
Yeah.
Great.
Let me see.
It's so great to see so many of you that I've worked with before. It's wonderful to have you all here. And just to give you a little background, I'm a geriatric mental health counselor, and I have the great joy of working both in with residents and with practitioners. So I get both sides of lots of conversations. This is a really wonderful conversation to have. I'm usually talking with you, the providers, and with the residents, trying to formulate this conversation. What happens in the denial of diagnosis? So this is let's see if we can turn to the next slide. This will be a really actually a fast conversation, because a lot of this are things that you know. Basically, the 2 points I wanted to bring up was the difference between denial and anosmia, which I always mess up saying that word correctly, but basically denial is a family situation. The friends and family are in denial about the process of the dementia situation happening. And family, friends are feeling embarrassed. They're feeling anger. They're feeling resentment. They're feeling grief, and really not dealing very well with the situation at hand and as it develops. The anosognosia, say it with me, people, is actually a damage to the brain that actually causes the person with the disease to not recognize that they actually have anything wrong with them. They, no matter how much you tell them that they have it, they're not going to recognize that they have it, and no amount of convincing them or showing them is going to change their minds. This is a common element in Alzheimer's disease, but it also shows up with people with brain tumors, with strokes, and also other kinds of mental health conditions, schizophrenia, bipolar disorder, post-traumatic stress disorder, things like that. So we can see this coming up where somebody is just going to have something that basically shows no insight to their situation. This is a different condition than the denial that a family has. A family we may be able to walk them through and help them change their mindset and help them along the way. Whereas a person who is just having no insight, we will be treating them differently with their process. And we'll turn to the next slide. All right. Basically, how do you help somebody who is not recognizing that they have dementia? We don't try to convince them that they have dementia. And the second point, we work with their doctors and their care team. And this may be, for you that are providers, this will be an interesting point, because I will go to people, I'll go to a resident and I'll say, let's go to your doctor as a, as an authority figure. And a doctor is an authority figure, and they oftentimes are the person that may be the most trusted person. Now, oftentimes a resident may say, you know what, I don't trust my doctor. I will fire my doctor if my doctor tells me this result. So if you're in that situation, you have a patient who is not validating your result to them, this is where I would say, let's bring in more troops. Let's look at the numbers of, the safety of numbers of the expert team that you can gather around them, which would be the neurologists, the therapist, your physical therapist, occupational therapist, speech therapist, who can also validate these proof points of testing and bring that back. And you're giving a mountain of evidence to the care team, the caregiver, and the resident, that even though they don't believe the information that's coming to them, you're giving them valid information that they can't exist in the situation that they have going on right now. So whether they believe it or not, these are the proof points, and these are the recommendations that you have to go on. That usually, whether they like it or not, this is the information you have to go on to help them stop driving or move into a higher level of care, or other such changes that you're making the recommendations for. The third point, discreetly make their life as safe as possible. So this would be things like taking the keys away from the car, or taking the car in to have the car repaired and not bringing it back. Changing where you're parking it, making those kinds of subtle changes that kind of complicate a resident's life or a patient's life so that they are kind of hamstrung a little bit, but they don't directly bring it back to the caregiver. So you're kind of giving the caregiver hints to help them out. If a caregiver is in a situation where the patient or the person with dementia is really pressured to, you know, I need to go to, I still need to go to my job. I still need to have a key to the house. I still need to have a key to the car. You can make subtle changes to that in a way that that saves space, basically. So taking the distributor cap off the car, the car is not working functionally, or you're loaning it to a family member and they're going to take it on a trip someplace, something like that. Some kinds of these the discrete, you know, discrete white lies that we try to tell to get somebody to reframe it and move on with something else. Third, the fourth point, avoiding correcting them and having confrontations. Really choose your battles. Sometimes we just have to let them have the point that they need to make where we are. And so choose your battles. The next point, present solutions positively and being subtle about that. And then finally, learn more about dementia and dementia care techniques. Just do everything you can to, again, join groups like this, keep talking with your peers, being open to novel new approaches, and really seeing what's going on in the community as far as care options, what's going on with new technology, what's going on with care support, and so that we can keep giving new opportunities for caregivers to support people. All right, so now we are done with our tips. I'm going to give you 3 different case studies so we can look at some complications that come up with, and we'll go, we'll look at some nuance. All right, so let's turn the page. Case study 1, Mary Moore. Mary Moore is an 82-year-old Caucasian female who is diagnosed with dementia after experiencing serious cognitive decline following a back surgery. She's lived independently in a CCRC and is experiencing many health issues related to inability to manage medications or follow medical directions consistently. She refuses the recommended pharmacy bubble packaging program because it costs more than her 3-month mail order supply through her health plan. She's fired private duty caregivers who have been hired to ensure that she takes the medications and follows treatments properly. Her DPOA for health and finance has been recently diagnosed with ALS and no longer can act in that capacity. The PCP has requested initiating formal guardianship proceedings. There is no other appropriate family or friends in Mary's life who would be appropriate for nominating for this role. Mary does not believe she has dementia and wants the doctor to remove the diagnosis from her files. So this is a interesting complication because she does not believe she has dementia. She has no appropriate person in any stead to act as her healthcare or financial POA. And she is not understanding that she can manage her medication or her finances properly. She is living independently, and she also has a very, very, very large estate. So she is very prone to financial abuse. She's also has a very philanthropic nature, so she loves giving money away, especially to her favorite university, who comes and asks for a lot of money from her often. So that's one case study that has a lot of relevance to me currently. And that could be a point that we could come back and chat about if we'd like. We can move on to our second study. All right, case study 2 is Jack and Jill Smith. Jack is an 86-year-old Caucasian male with dementia. Jill Smith is his 79-year-old wife and caregiver. Both live independently in a large retirement community. Jack exhibits poor executive functioning, unable to pathfind or order his day without complete supervision. Jill does not help Jack with reorientation, but often berates him when he does anything wrong, like putting salt in his coffee instead of sugar, or layering multiple shirts or pants inappropriately, or gets lost on his way to the mailroom, or pick up something she asked him to retrieve. When house-wide vaccinations are scheduled, Jill will bring her medical cards and fill out her paperwork, but will not assist Jack with his. Jack frequently wanders away, and Jill does not seem to understand that it is her responsibility to keep track of his whereabouts as the caregiver. Jill is not interested in attending caregiver support groups or getting private duty caregivers to give her a break. Their adult children do not intervene, even after a family conference called by the community to give an ultimatum to provide more support or vacate the premises. So that might seem a little familiar to some people as well. And then we'll move on to the final case study, which is Angela Doe. Angela Doe is a 96-year-old Caucasian woman of Italian descent with the diagnosis of dementia with paranoid features, living independently in a CCRC. Her best friend, Connie, is a Swedish woman in her early 80s and is her DPOA. Angela was a nurse in her career years and will often tell her PCP that I'm not crazy, I'm not losing it yet. I know these things, and I know I know these things, and I'll know when you can put me in the nursing home with the other crazies. Connie reinforces Angela's beliefs, stating, "We Europeans don't believe in this mental health crap." So she's losing her memory a little. She'll absolutely die if you make her go to assisted living. She's much better off here in the independent apartments. Meanwhile, Angela is a high utilizer of staff time and energy, making complaints to people that people are breaking into her apartment and stealing things, or standing over her bed and watching her sleep. Her stove has been turned off right after she moved in, as she burned a plastic tub in her oven. She often is fearful at night and cries that people are trying to break in and attack her. She does not take her meds correctly. She refuses the idea of assisted living or paying for caregiving help. So that is our third case study. And I thought at this point, with any of those case studies, we could have a little bit of opportunity to have a little discussion about those, answer any questions or any thoughts that came up for the group.
Thank you, Erica, for this great talk and these case studies, which I imagine have stimulated a lot of thoughts. So maybe we'll go in sort of backwards, and we'll take, well, first of all, any questions more broadly for Erica, or anything anyone would like to share. Brock, did you want to say something? It looks like I see your hand.
Yeah, I before you said we're going to start with case 3, I had a question about case 1.
Oh, yeah. Oh, okay.
Sorry about that.
Well, I thought just because we're on the slide, it seems like we could. Is that okay to go backwards? Or do you want to ask your, okay, we can do that too.
So for this case, I was curious where it says that the DPOA can no longer act in the capacity because of ALS. Is it that that person is no longer able to have a conversation with you about assistance in identifying a new DPOA?
Yes, so in this situation, and this is a composite. All of these are composite cases, but in this situation, this DPOA had been diagnosed, and their trajectory was very quick. So they were unable to act as the DPOA very quickly from within a 6-month period. Their ability to act as DPOA basically ended.
And there was no backup.
There was a healthcare backup, but the financial backup, the healthcare backup was somebody that Mary Moore absolutely loathed, and she was the one who appointed it, and she absolutely hated this person. So she refused to give this person ability to talk to her doctors or give her a medical portal, and it was her healthcare backup, the DPOA backup. The healthcare DPOA backup also said, "We've hated each other all of our lives." It was the DPOA, the primary DPOA's mother. So it was the DPOA's mother was the backup, and they hate each other, and it was a strange agreement. The financial backup was Chase Bank, and Chase Bank, they didn't appoint any person or any, so there was actually no relationship with the bank. So when he was no longer able to act as the financial, there was no succession plan with the bank. So the bank would not honor working with a person with dementia because there was no relationship with a banker. So we had to go through we had to move to a guardianship process.
I have lots of thoughts, but we'll hold back until see if other people have questions.
Thanks, Brock. Does anybody else now focusing on case 1 have any questions or any broader questions for the didactic for Erica?
I have a question. Yes, just that last statement, would Chase Bank have allowed a banker at their bank be a backup? Is that an option?
It was an interesting, it was put into the power of attorney paperwork and so I think that there was an understanding at an earlier time. In small banks you could do that, but in a large bank setting, that's much harder to pull off now, to just have a bank. Like small town banks used to be able to do that. You could go in, like on Bainbridge Island, where I grew up, you could go, if you had, because you had a relationship, you could go in and see your banker and things like that. It was easier to have a relationship and set up a banker. But you can't establish a bank, that kind of relationship if you don't know somebody in the bank like that. So it was a poorly set up power of attorney form in the first place. Yeah. Yeah, they tried to, they took it to the bank, and the bank's like, we don't know what to do with you, Also, that was written years ago, and with all these mergers too, they just didn't even know who, like that was years ago. That was a different JP Morgan, like what entity were you thinking of?
So it sounds like her POA paperwork had not been updated.
Mm-hmm.
It wasn't really current.
Right.
Any other questions or thoughts, ideas how to address Mary's challenges?
Well, Erica, I was also wondering how you happen to have a relationship with Mary, if she is in the denial of, or is not believing that she has dementia. What was the relationship when you first started? Was it more of a counseling relationship and it developed into discussing? Yes, please tell us more about your history with her.
Oh, absolutely. Great question, Julie. I'm a social worker in retirement community. And so I'm usually I'm a resource person for the independent residents, basically. So people don't come to me for mental health issues, they come to me for resource issues. So she came to me because she was having problems she knew that she was having some problems managing her finances, and she didn't know how to get around that. And then then I got involved with her her challenges because I knew that she was not happy with this bubble pack process that she was supposed to be doing with the pharmacy. Her doctor had wanted her to use have medical oversight to have her medication dispensed because she was not doing that successfully. She did not want to pay for that. The only way to do that in our community is through a bubble pack process, which is very expensive, you know, in comparison to getting a 3-month supply through the mail. She did not want to pay for that. So we've had to do a lot of adjusting to do some oversight for that, to kind of front load paying that until we get to work on some guardianship issues. So at this point, it took a while to build up a trusting relationship with her and get her to work with her attorney and our house attorney to move down the path of guardianship. We've also been going through a guardianship with all the new changes in the guardianship process that have come out in 2021. We're kind of going through a sort of an abridged guardianship process, and I'm still learning all the ropes of that since things have changed legally, what that looks like. So it's sort of a hybridized thing to get her a fiduciary professional who can help her with healthcare and financial issues that she will trust, because she has a lot of trust in a couple of key people that she has a lot of faith in, and luckily one of them is me. So keep that up.
Thank you, Erica. It sounds like that trust, as you said, really has been building over time through the relationship that you've cultivated with her.
Right.
Franja?
So yeah, thanks. So you touched on my question just a little bit, but kind of what I'm thinking about in this type of scenario is, we're always trying to optimize a patient's autonomy and by knowing their preferences and values around things. And so knowing that she could have maybe not decisional capacity because she doesn't have awareness of her cognitive deficits, but maybe still does have the ability to appoint a new decisional surrogate. And so I'm wondering, is that something that was tried with her? And, were there roadblocks there?
Yes, we looked through with her, we looked through all of the potential people in her life that may be qualified to do that. And we didn't find any. Basically, all of it, there were no family members that would qualify. Either they were not appropriate age-wise, or she did not trust them, so they didn't fit. And then
no friends either.
All of her friend group were 85 and over. And we said, I told her basically I refused to let her have any of her peers be that level of in that capacity for her.
So I'm curious. Oh, sorry, I didn't mean to interrupt.
Oh no. Well, because she has a very complex estate as well. And she has she has pretty profound estate matters, basically, and that she also has a tendency to go against medical advice from her doctor. So she would need somebody who would be willing to, not be fired all the time, something like that. Somebody who's not going to walk away from her. And so we thought if we get somebody who she just really likes, who's younger and vibrant, that she agrees to, she does have a tendency to stay with somebody who is a responsible professional that she has a trusting relationship with.
Thank you. Franja, did you have another comment or question? Okay, so I think I know we could talk about these cases probably for the rest of our remaining session, and I do want to give ample time for our case presentation. So perhaps we could go to case 2. Great, Jack and Jill. And this may remind some people in the community of cases that we've had presented at our Echo. I'm thinking of one in particular. So any questions for Erica or reflections or about case 2, Jack and Jill Smith?
This one's been particularly distressing because of the seeming lack of interest both within the spouse and the children. Usually you'll see some more interest, but at this point, for me, it becomes more of an issue of like having to kind of bring in our contract and say, you know, if you're not going to comply with these safety issues, we really have to, we really have to compel you to look at if this is the right place for you, because you're not abiding by the rules that you agreed to. So that kind of puts it back into, but having the conversation with the medical team is really important for this. Why are they so not caring about the situation or giving it the attention that it needs?
Nicole?
Erica, I couldn't help but wonder if you had any question about Jill's cognitive functioning.
Oh, definitely.
Yeah, that was the first thing that stuck out to me. Is she just unwilling to see her husband at this place, or is something more profound getting in the way of that?
Right. Yeah, and we're looking at cognitive screening for her as well, and or grief issues, or different things going on for her. So checking out to see what the family is doing, and where they are, where they're following up with their primary care physician to look at that too.
Great question, Nicole. Any other thoughts?
Yeah, this is Brett. This really points out one of the problems with, are these people married for a long time? I run into a lot of people who have these deep-seated resentments that come into their old age, and then they don't really care about each other, and the resentment turns into a knife blade almost. I'm just wondering if you see that with these people.
Oh, Brett, that is such an interesting idea. I think that is, I think there's something definitely, there's definitely something to that. And I think that that goes into that, is that an APS bucket we should be looking at too? Is this something like the punishment that you get for being this way or something like this? I think that's always a thought that we have to think about too, that you reap what you sow. Great point.
Nicole, do you have another question I see or comment? Or Denise?
No, sorry, that was a mistake.
Okay. No worries. Denise, so, questions around Jill's health status in terms of her cognition, the complexity of the relationship dynamic, and care and caregiving poses so many challenges, emotional, physical. Denise?
Yeah, what I've seen, and this reminds me of a case that I've had, is that Jill was very always the queen bee who was taken care of by her husband. And now that he's not able to do that any longer, she's very resentful of that. And family members are saying, well, she's just really narcissistic and she's always been this way. And she's having a really hard time coming to terms with the fact that now all this stuff falls on her. And so she's not going to have anything to do with it, either because of just her sheer personality, or, you know, in this case that we're looking at here too, I'm just wondering again, like the rest of you are, about her own capacity to deal with all of this.
Absolutely. You know, and which also begs the question, then why are you doing this? Why aren't you thinking about why aren't you two separating? And, or why aren't you going to the caregiver support groups, or why aren't you two out in the community where, you know, you can be with other people? You're in a community, but you can have other resources, like being with, you know, finding other, you know, coming to the memory cafe or other, you know, other opportunities, but they kind of sit and saturate with each other, and that's all that they do, is kind of, you know, they stay together the whole time. So it's kind of it's an interesting problem to see that no look towards resources or help or community, finding buddies or any kind of help like that.
Thank you, Erica. I mean, it really does sound like such a complex dynamic and challenging to navigate. We have a couple minutes maybe to look at case study 3, and then at 1 we will shift to our case presentation. So does anybody have any thoughts or questions about Angela?
This is Franja. I'm going to jump in, Nancy. I've got my hand up. That's okay.
Yeah, please do.
I do. You know, it's interesting, this one, because I would want to use a teach back to see, does this lovely friend really appreciate kind of, you know, the concerns and what can be helped. And so I'm wondering, was that part of the conversation, and was there kind of this deflection used, or can you fill us in a little bit more about that?
Oh, that's such a great question, Franja. Thank you so much. You know, it's almost like they're feeding into each other about any mental health issues. And dementia definitely equates mental health to both of them. That my memory issues are just a part of aging, and just get used to it. I'm a little old lady, and that's just the way it is. It's not, you know, as long as I can get up and vacuum, I'm fine. So that's kind of the way that they both kind of see things. And so leave me well enough alone. So Connie is really just feeding into this this whole thing. Like, you're fine being on your own as long as you can still get up and motivate around your apartment. We've turned off the stove. She's not taking her medications. We know that, you know, she's actually actively sitting up and having these perseverations and crises around the idea of people trying to break into her apartment. She's actually having these meltdowns on a regular basis, where she's thinking that she's being robbed or things like that. So she's having these anxiety attacks, and yet Connie is not being, she's saying, oh, it'll blow over, it's not a big deal. So the doctor cannot reinforce that either, because he's an American doctor. If we had a European doctor, they would understand, you know.
So it sounds like the meaning to them is a fear of loss of independence.
Right.
Yeah. Okay.
And no matter what, you know, me taking them to assisted living to show them it's not a loss of independence, it's actually more support, but which does not equate loss of independence. That's not going to fly, because Angela was a nurse, and I think her kind of nursing is sort of a Nurse Ratched nursing. Truly, I think she probably was Nurse Ratched. You know, from One Flew Over the Cuckoo's Nest, she really, I think that she thinks all nursing is like that. And so she's like, I'm not going to go to a place that's going to treat me like that.
thank you, that there's a level of fear and distrust.
Yeah, and
Deep distrust, yeah.
right.
So I'm going to, these are such rich case studies, and we could talk about this. And thank you for the questions and reflections. And thank you, Erica, for the really fantastic discussion about, you know, denial and anosognosia and these cases, which really illustrate the complexity of navigating all of the challenges. And I know I'll just mention briefly that we have some great didactics around, you know, advanced directives that Barack has given in the past and kind of updating those, and other resources on our website for people who are just joining today. And then thank you, Dr. Patricia Weber.